For a session produced by our underwriter, the Association of American Medical Colleges, please welcome Dr. Philip Alberti, Senior Director, Health Equity Research and Policy, and President and CEO Dr. David Skorton. They are here with USA Today's Bill Sternberg.
Good afternoon. So David, when we got together last fall, you were Secretary of the Smithsonian Institution, which is considered one of the best jobs in Washington. You had a big office in the castle. Why did you decide recently to walk away from that to return to your healthcare roots?
Bill, I thought your job was the best job in Washington. Well, it was a hard decision. The Smithsonian is an amazing place, right? A fabulous place. And yeah, it was super. And I loved it, but I missed the world of healthcare. I practiced for most of my career as a cardiologist. And we have so many issues in healthcare in our country right now, in our individual worlds, that I thought it was a wonderful opportunity to work for this organization.
Now, the nation spends trillions of dollars a year on healthcare, yet life expectancy has been declining, I believe, 3 years in a row now. What are some of those biggest issues in healthcare?
Well, one that affects most of us, no matter who we are, no matter where we live, is the balance between access and coverage. We want to have access to health care, and we want to have sufficient coverage that we can pay for it. And so the cost of health care and its availability are a big, big issue. That's one. There are, as we'll hear in a little bit, some things in our social environment that can gravely affect our lives and the lives of our loved ones. Right now, I'm very worried about gun violence in our country. And a third one, which unfortunately is affecting families all over the country, rural, urban, you name it, is the opioid epidemic, addiction in general, and mental health in general. So those are three that keep me up at night.
Let me ask you a little more about the opioid epidemic, which has turned into one of the biggest man-made health crises in our nation's history. Doctors played a role in fueling that epidemic by overprescribing pain medication. What role can medical colleges play in educating future physicians about pain and addiction?
What a ubiquitous, terrible, terrible problem. And I remember clearly early in my own medical training many years ago where it was felt that we were under-treating pain in some patient populations, and the pendulum swung a little bit far. So what we're doing through the AAMC, where I work, and through medical schools in general in this country, is changing the curricula, making sure that people understand, not only those in medical school, but practicing doctors, the latest information on how to handle pain, how to handle addiction, how to handle the underlying, sometimes mental health issues. Very important issues. We're working on it. A lot of work needs to be done.
And how about people who are already practicing?
Well, that's one of the big challenges in any profession, is to keep up. And a lot of complexities in terms of pain, and there's many other kinds of addiction not related to pain. So there's a big effort on way, and we're not there yet. We have a lot more work to do to make sure that not only are the doctors coming through the educational system, learning what they need to know, but those of us out in the world practicing are able to keep up and learn the best approaches to a complex problem.
So Philip, there's a lot more to health than doctors and hospitals. What are some of the social determinants of health?
That's a great question. So we've spent, I think, the last 10 years or so focused this health conversation on issues of health care, right? Insurance coverage, drug pricing, access, hugely important issues. But the science tells us that all of that work that happens in a doctor's office accounts for about 20% of what makes you healthy, of what makes your communities healthy, of what makes the nation healthy. And the other 80% has to do with the conditions where we live and the social conditions, the community level factors. Let me give you an example. So a patient goes to a doctor, the patient has diabetes, doctor says take your medicine, get some exercise, and eat more healthfully. So great, that's that 20%, the clinical care. That patient goes home to his house. Question number one, how far does he have to travel to get fresh fruits and vegetables? So is it closer than the convenience store across the street? If he can't walk there, can he take a bus there? Is there public transportation? Is it one transfer, 3 transfers? Who knows? And even if he's willing to go that far, is he willing to kind of take that 2 extra hours from his day if he's cobbling together his livelihood from 3 part-time jobs because his rent is 70% of all of his take-home pay. So those social factors, transportation, housing affordability, access to fresh fruits and vegetables, et cetera, that counts for 80%, right? So for the healthcare to work, for that patient to follow what that doctor said, for the healthcare to work, the rest of that ecosystem has to work too. And so we're trying to innovate right now on how to connect healthcare to all those other nodes in that ecosystem.
Right. But some commentators say medical schools should stick to the science, basic science, and should not teach social justice issues. Do you each agree with that?
I could not disagree more with that. I think it's a false dichotomy. It's both. Of course, we want our physicians to be competent and grounded in science, of course, and skilled. But at the same time, again, their health care is provided in a context. And if the care team, it's not just physicians, it's physicians and nurses, community health workers, social workers. If that care team isn't providing care, understanding the lived experience of their patients, the health care won't work like it could.
David, do you see a way to incorporate that in a medical school curricula?
Well, we're doing that now, but I just want to first endorse what Dr. Alberti said. If problems came to us in the real world segmented like that, this is a problem that can be solved completely by science. It happens once in a while. That would be one thing. But our thorniest problems don't come to us that way. They come as a combination of the things that healthcare can deal with and only the social determinants can deal with. So what we're doing is, throughout the nation, despite some controversy recently, we're broadening the education to make sure that doctors understand not only the science involved, the anatomy, the physiology, and so on, but understand, as Dr. Alberti said, the context, and therefore how you have to view the patient and treat the patient in his or her context.
I've heard you use the term academic medicine. What do you mean by that?
So there are about 150, roughly, medical schools accredited in the United States and 17 in Canada. And these are places that we're familiar with. Perhaps some of our relatives are applying to med school or in medical school. And they are learning in an environment which we refer to as academic medicine. It includes the whole spectrum of education and training from the day an undergraduate gets into medical school and starts that journey to post-MD, residency, fellowship training, and so on. So that's one aspect, education and training. Secondly, we want to keep moving forward with research. Dr. Alberti's research in the social determinants of health is just one example of the kind of problem solving and discovery that goes on at the medical schools and many other places. And then thirdly, of course, is the direct patient care. And of course, a lot of patient care is done outside of medical schools or teaching hospitals, but many of the innovations that are later adopted by hospitals and physicians throughout come from this discovery work, this research work. So those three pillars, if you will, research and discovery, education, and actual direct patient care, that's the breadth of academic medicine. And what people like Dr. Alberti are doing is adding to those three the fourth pillar, and that is the community itself, and what roles the community plays in that health and well-being.
And importantly, so the clinical system can address a patient's social needs, right? We can make referrals to food banks, we can make referrals for job training, affordable housing, et cetera, but that's not going to change the community experience, right? That's not going to actually increase the presence or availability of affordable housing. So partnering with communities as equal partners and lending the voice of academic medicine to advocate for policies that will actually change the context so that healthcare can really do its job is part and parcel of that fourth mission.
For sure.
Well, we don't want to keep the Terminator waiting, so I'll wrap up with the way I do a lot of interviews. Do you have any good answers to questions I haven't asked?
Dr. Alberti, this has your name written all over it.
Well, just, one thing I think, just to bring it back to opiates, right? There are social contributors to that epidemic as well. So we're not going to solve the crisis by increasing how we train physicians or how we prescribe medications. It's also about addressing the social kind of helplessness and economic despair that people feel that turn to opiates, alcohol, et cetera. And so it's not just a clinical intervention, it really is leveraging all of those social and economic drivers as well.
And the only thing I would add, Bill, is for those out there, anywhere, who are suffering from mental illness, whose family members are suffering from mental illness, we got to get past the stigma of asking for help. There is help available. There's an increasingly robust set of skills that we can bring to the table. And we just have to help our loved ones and ourselves feel open enough to go ask for help in that dimension as we would in any other dimension. I very much hope that happens.
David, Philip, thank you very much.